which obstructive lung disease you are expecting in this case?
Sir, chronic obstructive lung diseases.
Okay, it can be, but do you know? I hope you know the definition of chronic obstructive lung disease, that is COPD,
Yes, sir.
uh, and chronic bronchitis. Okay, anyway, you move ahead. Matlab, you are suspecting mainly COPD.
Mainly COPD, yes.
Don't you have a, differential diagnosis of ILD in this case?
Sir, basically, patient is presenting with chronic dyspnea, so we can think for the COPD, interstitial lung diseases, and sir, bronchiectasis. But patient is not complaining of cough, so sir, chronic bronchitis is ruled out.
Okay, okay, you are mainly keeping COPD as the primary diagnosis.
Yes, sir.
Don't you think for continuous, matlab for more than 3 months of or consecutive 2 years of chronic bronchitis, even though the term was initially removed from the literature, then they reinserted in the recent Harrison also. Don't you think the term is not fulfilled with this symptoms? Only 6 months patient has the symptom. Don't you think ILD could be the possibility?
Sir, ILD could be the possibility, sir.
Okay, 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 move ahead. You are mainly keeping COPD as the first diagnosis and ILD as the second one. Yes.
ILD is the second diagnosis. Yes,
Let's
sir.
see. Let's see. Let's see. Okay.
Patient was apparently normal 6 months back when he started developing the breathlessness, insidious in onset, presented on climbing stairs and walking uphill, and relieved with the rest, which was actually MMRC grade 1 of the dyspnea. His breathlessness gradually progressed over a period of next 3 months to be present when hurrying on the level ground, for which he used to visit the nearby local health center frequently, where he would receive the nebulizations for the relief of the symptoms. Patient also complained of the sudden worsening of the breathlessness, which was associated with the chest heaviness 3 days back while working in the farm. He was not able to perform his routine activities and symptoms did not relieve on the rest. Patient doesn't have any history of orthopnea or paroxysmal nocturnal dyspnea, no history of diurnal variation and seasonal variation in breathlessness, no history of fever, cough with expectoration, wheeze, no history of hoarseness of voice, sore throat, and running nose, and no history of allergy was there.
Sorry for the interruption. As you thought of as obstructive lung disease, you should have asked the relieving and aggravating factors in this condition, isn't it? You
Yes,
are
sir.
suspecting lung disease, whether the patient has taken uh, any type of bronchodilator or
Sir,
not. You should have asked.
whenever he used to feel breathlessness in the past 6 months, he used to visit the local health center where he received the nebulizations with the bronchodilators and steroids mainly.
Okay, that should have been mentioned in the when you have mentioned no history of diurnal seasonal variation in breathlessness. Then you should have mentioned matlab, there is if there is any aggravating factor or if there is no there is a you should have mentioned the relieving factor as an inhaler.
Okay, sir. That
Okay,
should have.
move ahead.
No history of chest pain, palpitations, and syncope was there. No history of lower limb swelling. No history of night sweats, weight loss, and loss of appetite. No history of recent travel was there. He was taken to the nearby local government hospital where he was managed conservatively with the nebulizations and he was referred to higher center for the further management and brought to Mahatma Gandhi Hospital, Jaipur for further care. Past history. Patient was a known case of old pulmonary TB 30 years back. He took incomplete treatment as informed by the patient and his attendant, but no documents were available for the same. History of hospitalization 6 months back for the similar complaints in the Mahatma Gandhi Hospital, Jaipur, and was diagnosed with the COPD with right pneumothorax and old K chest. He was managed in the month of June with IV antibiotics, nebulizations, and oxygen support in the ward. Discharged on the Foracort Rotahelor. However, patient was not compliant to the drug. He was not a known case of hypertension, type 2 diabetes mellitus, asthma, or chronic heart diseases, and there was no history of any surgeries in the past. Treatment history. He was on Foracort Protahelor for COPD as prescribed in the last admission, but he was not compliant to the drug. He was also taking capsules, silodosin and dutasteride, HSOD from the last 6 months as he was complaining for the lower unit tract symptoms, and nebulization received SOS on the emergency basis. Patient is a pure vegetarian having a normal appetite with adequate sleep, and bowel and bladder habits are regular. He was a chronic smoker for 30 years duration, one BD bundle smoking per day, which amounts to be 30 pack years, and he quit smoking 33 years ago.
Nipun, one more query I have. The patient has symptoms for last 6 months, isn't it?
Yes, sir.
But he has quit 3 years ago. Matlab, why somebody will quit in between? Matlab, what was the reason?
Sir, actually,
There
his
should be some
doctor,
reason na, for quitting. Any occasion, yeah, something made, or his illness made him to quit from smoking.
sir,
Symptoms
actually,
are only for 6 months. He has quit 3 years ago suddenly. Why?
sir, he intentionally quitted the smoking after getting the symptoms of coughing with expectoration earlier. In the last 3 years, he was getting the symptoms of coughing with expectoration and shortness of breath was there, but significantly the complaint started 6 months ago.
But you should have mentioned na then. Whatever patient's ka words should be mentioned na.
Sir, actually,
You told matlab,
significant.
he was apparently normal 6 months ago.
Yes, sir.
Then why? What was the reasons? Okay. Anyway, matlab, these things to be considered. If the patient is telling like this, then you should recheck with your history. You should
Uh,
recheck the history.
so, Dr. Nipun, uh, can you just tell it again? Did the patient had cough with expectoration and breathlessness before also?
Ma'am, he complained like 2 to 3 years. He was saying that I had these complaints, but
Hmm.
that was resolved. But significantly, the complaint started 6 months ago only with the shortness of breath and chest heaviness.
I think if patient mentions something as I is saying that obviously the patient, I don't know whether it is like he told it significantly he left 3 years ago or not. Sometimes patient may or may not tell, or whatever detail could be just in because of the doctor's influence. But if it is correct, then you need to mention if a patient is having even a chest like cough for few days or few weeks or months, you need to mention that in your past history. Okay. Okay, you can go ahead, Nipun.
No similar complaints in the family, and no history of TB in the family was diagnosed.
Nipun, can you
Sir,
please enumerate the respiratory diseases which are running in the family?
uh, sir, on the genetic basis, cystic fibrosis,
Okay, okay,
emphysema,
okay,
like alpha 1 antitrypsin deficiency can run
o-
in the genetic.
okay, okay,
And sir, if there are any TB contacts in the family, tuberculosis could spread.
okay, good, good, good.
Sir, pneumoconiosis, any occupational hazard is there, then
If you think cystic fibrosis,
yes, sir.
uh, can you please tell the uh, genetic link of that particular disease, whether it is autosomal dominant, autosomal recessive, or X-linked or X-linked dominant or recessive? Can you please tell?
Autosomal dominant.
Acha. Okay. Okay, now go ahead. Go ahead. Just I wanted to give, you should be ready with this. When you put this pedigree chart, you should know certain diseases and their linkages. You should know. So I asked, not to humiliate, you are like my junior only. Okay.
Yes, sir.
Chick, go ahead. Nipun, you can go ahead.
Yes, ma'am. Yes, sir. Socioeconomic history. Patient was residing in a kacha house, 10 members in the family in one house, having outdoor sanitation, and drinking water source was from the nearby well. According to modified Kupuswamy scale, he belongs to the upper lower class, that is class 4 of the socioeconomic scale.
Dr. Nipun, I hope you might be knowing all the socioeconomic classes, the modified one also. I don't want to ask those things. What about what is the cross ventilation का definition क्या है? And overcrowding, what is the overcrowding बोलने का definition क्या है? You should know both these terms. I'm not asking now. You should know that, okay? Because when you are mentioning 10 members in a room, it's an overcrowding actually. Then you should know what is the individual space for a person. What is cross ventilation? All these things to be mentioned. You should know the definitions. Okay, you can ahead now from my side.
Nipun, hello.
Yes, ma'am.
Yeah, can you just elaborate, just tell what are the parameters you consider in modified Kupuswamy scale?
In modified Kupuswamy scale, we consider the three factors: education of the education of the head of the family, occupation of the head of the family, and total income of the family per capita income.
Okay. Okay. Yes, can go ahead.
Just next slide, please.
Yes, sir.
Please, Nipun, sorry for the interruption. Before going to the summary, can you please enumerate the six cardinal symptom of respiratory system? Cardinal symptoms of respiratory system. Did you cover in your history presenting illness?
Sir, mainly six cardinal symptoms of respiratory systems are cough, breathlessness,
Okay.
fever.
What? Pardon?
Sir, fever.
Fever.
Cough,
Okay.
breathlessness,
Go ahead.
fever,
Go ahead. Then.
and sir, chest pain,
Okay.
and sir,
Okay. Expectoration. You should mention about expectoration. That is sputum production. You should. Yeah. You should mention about the hemopsis, and you should mention about the wheezing. These are
Yeah.
6 cardinal symptoms. Whether you mention the rest of the things or not, cardinal symptoms should be in your presenting illness, whether it is that is present or not, because each one will be leading a different diagnosis. Okay. Okay. From my side, you can now summarize the thing.
Nipun, can you differentiate this dyspnea from the cardiac dyspnea?
Respiratory dyspnea in respiratory breathlessness, like respiratory cases, patient is complaining with the shortness of breath, but in the cardiac cases, patient is also having associated chest pain.
Okay, may or may not be there. Okay, what else? Why did you ask for orthopnea and PND?
Yes, ma'am. In the cardiovascular diseases, orthopnea and PND, paroxysmal nocturnal dyspnea, is associated with the cardiovascular events like congestive heart failure or any valvular diseases.
Okay, so that is towards the cardiac causes. Okay, why
Yes,
did you
ma'am,
ask for the long history of travel for this patient?
as to rule out the chronic sitting position, to rule out any cause of DVT or embolism.
Okay, so long travel and swelling of lower limbs. What does that justify?
If any pedal edema or swelling is associated, so patient may have the congestive heart failure,
Okay.
HF,
Hmm.
and cardiac abnormalities like pulmonary hypertension or pulmonary right-sided heart failure.
Hmm. What else?
Any valvular abnormalities like tricuspid regurgitation and all.
I don't think in valvular heart disease you will have a swelling of lower limbs until unless patient is having CHF. So my question is, a patient who is having acute deterioration in breathlessness or a sudden deterioration in breathlessness 3 days back, your patient had the same thing, right? So why did you ask for swelling of lower limbs One
to
is
rule out
CHF, one is your cardiac causes. The other thing is, if there is a unilateral swelling or there is DVT present, supposedly, then what will be your differential?
if DVT is present, then we can suspect of the pulmonary embolism also.
Okay, so what I mean to ask is, what are the differentials for the acute dyspnea?
Ma'am, in acute dyspnea, differentials include pulmonary embolism.
Hmm.
Ma'am, then we can think of infarct,
You mean infarctions, myocardial infarction?
myocardial infarction.
Okay.
Ma'am, then we can think of
You can
the
divide into respiratory causes and then cardiac causes. First, you can complete respiratory causes.
yes, ma'am.
So your patient is having 3 days worsening of symptoms, right?
Yes, ma'am. 3 days was something.
Okay. So can you elaborate? Can you give just 2-3 causes of acute dyspnea in which fits to your patient's history?
Ma'am, acute dyspnea cases can present like pulmonary embolism is the first cause. Then then we can think of like
Don't you think
infarct.
it can be infection also? Acute exacerbation of COPD due to
Yes, sir.
infection?
Yes, ma'am. Acute
Okay. What
exacerbation.
else?
Pneumothorax can be there,
Oh,
ma'am.
okay.
Pulmonary embolism.
Okay. In cardiac causes, you told already myocardial infarction.
Yes, ma'am.
Okay. Okay. Go ahead. You can
Uh,
summarize, Nipun.
yeah,
Yes.
1 minute, please.
Yeah,
Sorry
yeah,
to
yeah,
interrupt.
yeah, yeah, Dr. Shruti.
Uh, uh, Nipun, you have told orthopnea is mainly due to cardiac. Yes, I accept. But some respiratory causes of orthopnea also
Yeah,
are there.
yeah.
Those are mainly airway obstruction, diaphragmatic palsy. Okay.
Yes,
Even
ma'am.
in a severe respiratory muscle paralysis, in that condition
Mm.
also patient will be having orthopnea. Then how will we differentiate between orthopnea of cardiac plus orthopnea of respiratory system? In
Respiratory
that
muscle.
condition only, you should ask for PND, that is paroxysmal nocturnal dyspnea.
Yes,
PND is the first sign of cardiac failure.
yes, sir.
I meant first sign or first symptom, whatever you consider. Paroxysmal nocturnal dyspnea is the first one in the cardiac patient, but it will not be the first one in the respiratory patient. So
Respiratory.
those things will be, you should consider those important histories. Especially COPD patients with a severe bronchospasm, they cannot lie down. They will be
Mm.
having orthopnea. Severe
Yes,
bronchospasm in a bronchial asthma patient, they will be having orthopnea. So that orthopnea will be whether it is with respiratory system or with the cardiac system, you should ask by PND history. Okay.
okay.
I hope you know what is PND, Nipun.
Yes, ma'am.
Okay. You can ahead, Nipun. You can go.
As we summarize our case, patient is an elderly male, farmer by occupation, deformed smoker, known case of old pulmonary TB and COPD on irregular treatment, presented with the worsening breathlessness from MMRC grade 1 to MMRC grade 3 since 3 days, with significant past admission for the pneumothorax 6 months back. From history, it appears to be the respiratory system pathology, probably acute exacerbation of the chronic obstructive disease.
Okay. Nipun.
Yes, sir.
Reformed smoker. Yeah, that's a good term to use. Otherwise, we were using ex-smoker previously. When will you say a person is an ex-smoker? Ex-smoker. What is the duration for that? To comment on that.
Sir, according to me, we can call the ex-smoker as per if he has left the smoking for about more than 1 year.
Okay, good. As per foreigners guideline, it says more than 6 months a person quits, then he is an ex-smoker. But for Indian guideline, it is 1 year. You're right. Okay.
Okay.
Okay. Then mm, okay. Why do you strongly stick with this particular chronic obstructive lung disease?
Sir,
Why don't you
actually,
think of other diabetes in this case?
sir, patient was having the his chronic history of the dyspnea from the last 6 months, and he was complaining of the shortness of breath from like exacerbated from the 3 days back. So the primary thing which come in the mind is acute exacerbation of the chronic disease.
Okay, okay, okay. Take it. You go ahead with the DDs, then we will think of it.
In differential diagnosis, acute exacerbation of COPD, pneumothorax, pleural effusion, pulmonary embolism, and LRTI. Lower respiratory
Niput,
tract.
what is type A COPD? What is type B COPD? Do you have idea of these things? Because the patient had tuberculosis 30 years ago. He was an smoker, matlab now ex-smoker. So don't you think this could be because of post-TB COPD and exacerbation?
Yes, sir. He was a known case of old case chest, so reactivation of TB could be the equally for the acute exacerbation.
No, I meant that is type B COPD. We used to call some secondary causes ka wajah se the patient develops COPD, that it is type B COPD. In that case, the classic definition will not fit in that particular case. For example, more than 3 months in a year for consecutive 2 years of illness. That was the chronic bronchitis or COPD definition initially. Still, we are following somewhat. That will not be followed in the cases of post-infective COPD. Could it be the first DD?
Sir,
I meant post-infective, that is post-tuberculosis COPD. Will be the diagnosis or not?
yes, sir. It can be the diagnosis.
Because patient has only the 6 months of history. Okay, why not ILD?
The
ILD
ILD,
patients also will be having chronic respiratory breathlessness, and they will be having an exacerbation of that. Why not ILD?
sir, in interstitial lung diseases, the patient, as he was not exposed with the like any particular agent like dust or smoke, so and ILD could not be ruled out.
Okay, so many ILDs are there. Those are called um, those will not be having exposure history. Those idiopathic interstitial pneumonias and
Yes,
certain
sir.
ILDs, we don't know the reason. Matlab, we don't know the cause. And certain ILDs, they will be having for like connective tissue related ILDs, they even though your history is not suggestive of any skin or joint symptom,
Yes, sir.
uh, those people will not be having exposure. Okay, can you please tell 3 ILDs with known exposures? Matlab, this A hai to then this type of ILD can happen.
Sir, like in pneumoconiosis,
Okay,
occupational
good.
lung
But but
pneumoconiosis.
but what do you think pneumoconiasis? What type of ILD you are expecting?
Sir, in occupational ILD, like idiopathic pulmonary fibrosis can be there in the, and then asbestosis.
Man, actually, those things will be causing okay exposure based ILD. Those are okay.
Exposure based
Then
ILD, yes, sir.
okay, silica or asbestos. Okay, then one exposure pneumoconiosis you have told. Then
Then, sir, we can think of the exposure related hypersensitivity pneumonitis.
very good, very
Yes,
good.
sir.
Then one more, please.
Drug induced uh,
Okay,
ILD
good,
could be there.
good. Some
And
classifications are ILD are there. You should know about that. You please go through it later. You should know. Okay, why not? It is bronchial asthma
the bronchial asthma is mainly associated with the wheeze, but no wheeze was there in the
and
patient.
COPD also will be having these. Then how will you label them?
The bronchial asthma is
Man, what is the difference between Ronke and V's?
wheeze
I
could be
should ask
heard.
in the clinical examination only, but I'm just asking as you have opened up the term. What is the difference between V's and Ronke?
The wheeze could be heard without any aid of
Okay,
specific
good,
sound.
good, good. Okay, I got it. I got it. Look, Uh, okay.
The whistling sound.
Some patients, COPD patients also will be having V's. Then how will you label them? Don't you, will you call them only bronchial asthma?
Those are
See, V's
bronchial.
are this Ronke are mainly due to airway narrowing. because of bronchospasm or mucus secretion, or even in foreign body also you will be getting because airway narrowing. Why not bronchial asthma in this patient? Okay, no seasonal diurnal variations, only adult onset, especially late onset asthma is a very rare one. I consider all those things. Okay, why pleural effusion? Why pleural effusion?
Sir, as patient was complaining with the acute exacerbation of the acute exacerbation of dyspnea, so pleural effusion can be the cause.
For one symptom you are telling one DD. If the patient has pleural effusion, the history would have been different. Cough would have been there initially. Then only once the pleural space fills with fluid, then only the cough may disappear. May disappear, not with all patients. And the positional changing might be helping in this patient.
Yes, sir. Position change.
Orthopnea might be there in pleural effusion because in a massive effusion, as he developed 3 day symptoms, matlab, in that stage, orthopnea might be there. Those histories were not there, but you are keeping. Why do you keep pleural effusion in this case? You should think of it. These like DDs, you should think of it. Okay, why pulmonary embolism? As madam asked, whether the patient had any unilateral limb swelling.
No, sir. Unilateral limb swelling was not there, but sir, suddenly patient presented with the breathlessness, so we can think of the pulmonary embolism.
Okay, you want to think of it. Okay, did you ask for then hemopsis?
Yes, sir. I asked, but no complaint of hemoptysis was there.
You didn't mention now.
No, sir.
Okay, okay, okay. ठीक है. I pneumothorax I understand because patient had already pneumothorax. So now you are keeping the pneumothorax recurrent. What is the definition of recurrent pneumothorax?
Sir, recurrent pneumothorax can be called when the patient is complaining with the shortness of breath in a period of 3 months.
I meant what is the duration between the two pneumothoraxes? Recurrent means at least two pneumothoraxes. What is that? It should be at least 7 days. Okay, at least 7 days difference between the two pneumothorax with radiological evidence of resolution. Then only it is recurrent pneumothorax. Okay. Okay. Why LRTI? Why LRTI?
Sir, LITI, I put it in the last as the differential diagnosis because the patient was not having any complaint of fever or like cough with expectoration was not there. So I kept it in the last as a differential diagnosis.
Okay. 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 Go ahead, man. Go ahead. You don't have other EDs, you know?
Yes, sir. These are
Okay. Okay. No issues. No issues. Let's see with the clinical examination whether these findings are fitting with this history or not. From my side, you can go ahead, man.
Nipun, are you there?
Yes, ma'am.
Yeah, go ahead, no?
Ma'am, Kanika, ma'am.
Mm. Okay.
Dr. Nipun, you can continue.
Yes.
Nipun,
On general
be
physical
confidently
examination.
present, karo. We are just seniors to you, bus. We are not torturing you. We are just educating. Our way of educating will be different. You
Yes.
can present.
Yes.
I also did my MD from Rajasthan only, man. Present, you can present.
Yes. On general physical examination, patient was examined after taking a consent in a sitting position. Elderly male, thin built and nourished, conscious, cooperative, and alert. Supraclavicular hollowing was observed on both the sides. The patient was lean. He was well oriented to time, place, and person. Height calculated to be around 158 centimeter. Weight was 54 kg. BMI is 21.63 kilogram per meter square. Pulse was 84 beats per minute. Regular rhythm. Normal volume and character. No radio-radial and radio-femoral delay. And all peripheral pulses were felt. No basal wall thickening was there.
Nipun, I would like to correct here itself.
Yes.
Previous slide, please. Yeah. You have mentioned the supraclavicular hollowing observed on both the sides.
Yes, sir.
It's a normal one or abnormal one?
Sir, Basically, supraclavicular hollowing was there as patient was very lean, but supraclavicular hollowing was can only, also be seen in the patient having emphysematous finding.
What, man? I was asking that only. The persons with emphysema, according to your DD, first DD, the patients will be having fullness of that
Yes.
supraclavicular fossa.
Patient with fibrosis can have supraclavicular hollowing.
Yes, sir. Yes, ma'am. Patient with fibrosis will have the hollowing.
Yes, okay. So post TB COPD will be more fitting with your diagnosis, your first, your
The first
presentations.
GP thing.
Yeah. Anyway, and you should know about BMI and COPD. You might be knowing the formula for BMI. I don't want to go into that. Indian categorization of BMI will be different from the World Health Organizations. That also you might be knowing. If you don't know, you should know. Why BMI is important in your case, especially you have put the first TD as COPD. Is BMI important in this case or not?
Yes, sir. If the patient is like having higher BMI and is obese, the patient can have the more chances for the development of breathlessness.
No, man. No. This is the logical mistake you did. Actually, there is a index called board index, mainly for obstructive diseases. Uh, that it can be used for all chronic diseases. What is
And
B for BMI? O for you just to go through that. In that, when the patient has a lesser BMI, they have more
then he is
more.
associated with
They have,
sir, actually,
but
if
that
is
not
having the higher BMI, so is associated with the obstructive sleep apnea something.
okay. You wanted to say some other. Okay, okay. What should be the BMI level in obstructive sleep apnea?
Sir, it should be more than 30,
30.
more than 30 kilogram per meter square.
Okay, okay, okay. BM board index is an important one. You should know. Okay, 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 man. Go ahead.
Respiratory rate was around 28 cycles per minute. Abdominal thoracic pattern. Blood pressure was around 130 by 84 mmHg, measured in the right upper arm in the lying down position. Temperature 97.6 degree Fahrenheit, measured in the axilla. Failure present. Grade 1 clubbing is seen. No cyanosis, icterus, koilonychia, edema, or lymphadenopathy. JPP was not elevated and spine was normal.
Nipun,
Yes, sir.
respiratory rate is 28. Okay, then how will you label this? Tachypnea or something else?
So tachypnea is there.
Okay, what is the value you will say the patient has tachypnea?
Sir, if the patient is having more than 20 cycles per minute, we can label the patient as tachypnea.
Okay, I would like to highlight there only. Some of the clinical books say more than 20. Some of the clinical books say more than 22. And the same way, bradycardia also, some of the books say less than 12. Sorry, bradypnea. Bradycardia nahi hai, bradypnea. Some of the books say less than 12. Some of the books say less than 10. Okay, you should aware of that. So I asked the question. Okay. Uh, what grade 1 clubbing means? What you
Sir,
would like to say?
grade 1 clubbing is actually when we observe the increased fluctuation in the nail bed. Normal
Okay.
appearance and angle is normal, but fluctuation of nail bed increases in the stage 1 clubbing.
Okay, you might be knowing all the theories of clubbing, unilateral clubbing, digital clubbing, everything you might be knowing. I don't want to go into that because you might have read that thing. But I would like to say one thing regarding this. When we present the respiratory case, we will not mention the grade generally. Generally, why? Because some of the clinical books again say grade 3 and the grade 4 के बीच में confusion चल रहा है. Some books will say parrot peak is the grade 3.
Yes.
Okay. Hello.
Yes, sir. Grade 3
Some
is parrot.
some of the old books say parrot peak appearance is a grade 4. So we don't comment on grades generally. I'm just giving the awareness to you regarding the clubbing.
Okay, sir.
What is the best way? Okay, grade 1 you are telling grade 1. What is the best way that is the gold standard to say about the patient has clubbing or not? Grade 1 you can say grade 1 clubbing. I will say there is no clubbing. We will be having conflicts between us. Like, what is a gold standard to say clubbing?
Sir, when we can
The
appreciate
technique.
the
No, man, no, that is not a clinical one. That's a measurement one. We will be,
sir,
hello,
yes, sir.
we will be measuring the anguinometer. That will be
Angular.
measuring the nail bed angle.
Yes.
It's a
Yeah.
angle measuring. Okay. That is the finest one and the gold standard one. That will tell what is a normal angle, man.
Less than 10 degrees, sir.
Less than.
10 degree.
Okay.
Less than
Okay.
180 degree, like if we are seeing in a straight line.
Okay. Matlab, you are 180 ka, you are seeing that 10 degree, but book say this 164 degree. You are
Less
180
than
mein, you are
180
telling
degree.
that 10, but book say 160 ka upar hai to. Then consider those things. These are basics. You should be very clear with that. Okay. Cyanosis. Why do you suspect cyanosis in this COPD patient?
Sir, in cyanosis were not there in my patient, but sir,
Okay.
if we are suspecting about the hypoxia, so cyanosis can be observed in the patient with hypoxia.
Okay. Do you think what is polycythemia? What is
Sir,
polycythemia and the types you might be knowing, primary, secondary? COPD patients will be smokers.
yes, sir.
Because of their chronic hypoxemia, their their hemoglobin level will be higher in those patients.
Yes, sir. HP count is high.
Okay. So those patients will not be easily having cyanosis. So you should think of when they have cyanosis, it means something else. When why pallor? Why COPD patients will be having polycythemia, but this patient has pallor? What does it mean?
But patient was having pallor because sir, maybe the sign of chronic disease, anemia of chronic disease, maybe there.
Okay, anemia of chronic disease. Okay, one possibility. Generally in respiratory system, what we say in a patient of COPD has anemia or pallor, we will be very cautiously. We will be looking into his chest because because those people will be having anemia because of malignancy
Yes, sir.
mainly.
Malignancy.
COPD patient will be a smoker. COPD itself a risk factor and smoking is a risk factor. They will be having malignancy. So those people ka anemia might be due to some other reason. They will not be easily having anemia. Okay. Your patient has a post TB. Your patient is a post TB one, so he might be having post TB bronchiectasis. Everything might be there, but your history is not suggestive of cough, productions, everything. But in those patients also, they might be having nutritional anemia.
The nutritional deficiency can be.
Yeah.
Nipun, you want to highlight the past admission thing? I mean, I know the case, that's why I'm asking. A patient had MCV of 102.
Yes, ma'am. Patient was having in the past admission higher MCV. So, sir, megaloblastic anemia can also be the cause for the failure.
Can it be a nutritional cause?
Yes, ma'am. Nutritional
Because
deficiency.
you said patient is vegetarian also,
Yes, ma'am. Vegetarian diet is there.
and that
So,
to 75-year-old male.
yes, ma'am.
Okay.
Yeah, that might be also one of the cause. Okay. You can go ahead from my side, man. JVP, I would like to say each point where some points, some notable things are there. I would like to say those things to you, man. So I am asking, don't take
Yes.
कोयला नहीं किया बोल दिया आपने मतलब you have mentioned कोयला नहीं किया, so iron deficiency also might be there, so he might be having pallor. लेकिन why the patient has uh, and iron deficiency that to be mentioned. Lymphadenopathy, uh, do you know? I hope you might be knowing how to check the lymph nodes of cervical, axillary, and abdominal, and uh, I hope so, man. You should know.
Yes, sir. By palpation method, we are checking.
Okay. Generally, COPD patients will not be having clubbing. But why
Yes,
your
sir.
patient is having clubbing? If you go through the literature, if you go through the books, COPD patients will not be having clubbing.
Yes, sir.
If they have
COPD.
clubbing, then it means something else. How will you explain the clubbing in your patient?
Sir, as he was a chronic smoker, So might be some other causes can be associated for the
Yeah,
clubbing.
post TB you told na.
Post
Post
TB
TB patients, post TB having fibrosis, cavitary lesions, bronchiectasis, those like abnormal anatomical destructions might be there. Those patients will be having clubbing. That can be explaining. That can be explained. If the patient has malignancy, then also will be having clubbing. Okay. Anyway. Okay. Next, what will be the first finger you will be checking for? You will be checking. What will be the first finger?
The first index finger we will check for the clubbing.
Okay. Good. You might be knowing the reason because both ulnar and radial artery are supplying to the index finger. है ना?
Yes, sir.
Okay. You might be. Okay. If the patient, your patient is our old professor's question. If the patient does not have index finger, then where will you check the clubbing?
Like
Other fingers में check करेंगे, ठीक है? My professor will be telling the patient is an amputated one. Then where will you check the clubbing? Then you will be telling toes में check करूँगा. Okay, the patient is our professor will be telling, okay, the patient does not have both upper limb and lower limb. Then where will you checking the clubbing? Or cyanosis, where will you check the cyanosis? मतलब in other way, mucosa, है ना? Clubbing के लिए in other sides of clubbing you should know. So why I am asking, not to humiliate, other sides of clubbing where to check. I wanted to point it out. Okay, go ahead, man. Go ahead. Things are there to discuss. As of now, we have to move ahead. Go ahead, man.
in respiratory system examination, upper respiratory tract, on examining the nasal cavity, nasal septum was deviated to the left side. Oral in oral cavity dentures were present, and pharynx appears normal.
Nipun,
Yes, sir.
what are the respiratory conditions are associated with upper airway involvement? That is upper respiratory system involvement.
Sir, pharyngitis.
Leave all those acute causes of infection, infectious causes. Say some conditions involves both upper airway plus lower airway.
Both
Then
upper
why
and
did you
lower.
check? Why did you check upper airway? Why it is important to respiratory system?
Sir, to rule out any causes condition causing pharyngitis or DNS, deviated nasal septum.
Okay, man, I understand. Sinusitis, bronchial asthma is you want to rule out to those allergic related. Okay, one cause. Then
Dr. Nipun, what sir is asking, conditions which affect both upper respiratory and lower respiratory tract.
Ma'am, obstructive sleep apnea.
Anything else?
Man, Nipun, can you please tell me what is the borderline for upper airway and what is the borderline for lower airway? Nipun, I am not bombarding you. I am telling, I am teaching others in a different way. Who are listening, है ना? 44 member participants are here. I am telling them the things in a different way. Don't take into heart, man. What is the demarcation for upper airway and lower airway?
Where does upper airways and when you call that lower airways start? That's what he's asking.
Sir, at the upper airway terminates at the level of pharynx.
Okay.
Nipun, what is the significance of manubrium sterni anatomically?
Sir, ma'am, is the landmark for the angle of carina is the main point where the bronchus divides. So
For this also, man, if you go through the literature, they are confusing you. Generally, the vocal cord will be the cutoff, but some books say, as you said, the carina के नीचे lower airway, उसके ऊपर पूरा upper airway. But what we follow, what we follow, vocal cord के नीचे lower respiratory tract, vocal cord के ऊपर upper respiratory. That is the thing given in most of the books. You should know that.
Below the glottis.
Okay, man. Okay, see, you should know sarcoidosis क्या करता है, tuberculosis क्या करता है, vaginous क्या करता है. You should know, you should enumerate like the things because you are checking upper airway, na?
Yes, sir.
Okay. Go ahead from my side. I'm okay with this.
Okay, Nipun, go ahead.
On examining the lower respiratory tract, on
Man,
inspection,
if you want to upper airway, then you should mention about properly the ear okay, nose okay, you should oral cavity okay. You should mention all the three things. मतलब okay means normal मतलब at least
ear,
you
nose,
are
and
you have
mouth.
ear also should be mentioned in this. Okay,
Okay, sir.
ear also should be mentioned. Okay, next.
On inspection, chest is barrel shaped. Trachea appears to be slightly deviated towards the right side, and apical impulse cannot be visualized. On seeing the movement of chest, on the upper anterior chest, both right and left side was normal, and the lower anterior chest, right side was diminished, and left side was also diminished. Upper posterior, right side was diminished, and left side was normal. And on the lower posterior chest, right side was diminished, left side was also diminished. In drawing of the bilateral lower intercostal spaces was seen. No dilated veins, scar, or sinuses were visible on the chest wall, and the spine appears normal.
Okay, Nipun,
Yes.
it is not needed for a family medicine case presentation. What are the areas of lung for observation matlab to inspection or for auscultation
Sir,
areas?
on the anterior side, we auscultate or inspect the supraclavicular, then
Okay,
clavicular, then supraclavicular, axillary,
ask.
supraxillary,
Okay,
and sir, on the
okay.
posterior side, we are examining the suprascapular, scapular, and the infrascapular area.
Suprascapular,
Interscapular.
infrascapular.
Suprascapular, infrascapular, interscapular area.
Okay, actually older books say inframammary is a area. ठीक है, लेकिन nowadays मतलब we don't use that area. I just would like to say that. Okay, you want to say indrawing. What does it mean, man? Indrawing of bilateral lower intercostal spaces. What does it mean?
Then, like on observing on the inspectory findings, the lower ribs were like in the patient was in the gasping state, so we observed the indrawing was there in the lower intercostal space.
Okay, okay, you want to say something. Uh, okay. Inspection, can you please, previous slide, can you please show the previous slide? Previous one, yeah. A barrel shaped, what do you mean by barrel shaped, man?
Sir, barrel-shaped chest was there when AP diameter is more than a transverse. Like when we observe the anterior-posterior side was like measurements were more as compared
Okay.
to the transverse.
See, okay, it is okay. You have done a good narration of the inspectory findings, but always whether it is a symmetrical or asymmetrical chest. Symmetrical, then only the shape should be. But because your patient had a tuberculosis history also,
Yes.
and you are telling supraclavicular hollowing is there, and you are telling barrel shaped chest. Then, so whether the chest is symmetry or unilateral, one side is affected more or the other side is affected less. That in that way, symmetrical should be mentioned. Symmetry should be mentioned. Then chest barrel shaped you have mentioned okay. Tracheal and apical impulses you have mentioned okay. Then next slide please. Why matlab upper posterior chest has normal on the left side. Matlab it means the chest is not a symmetry one, na?
Sir, chest movements were more diminished on the right side.
Okay, it means asymmetrical chest disease you are dealing.
Yes.
So now also matlab your findings are more favor of post TB COPD because COPD में why should the patient has is in these like asymmetrical findings, है ना? Okay,
Yes,
okay,
sir.
then you might be knowing the what is scoliosis, what is the angulation to say scoliosis. Spine normal you have mentioned.
Yes.
What is scoliosis, what is kyphosis?
Sir,
What is
in
kyphoscoliosis? Just tell.
we measure the sir Cobb's angle to differentiate.
What
Can you
should be the
define
Ma'am, in scoliosis, there is a sideway curvature of the spine.
what is kyphosis?
In kyphosis, there is the outward curvature of the spine.
Okay. Okay. matlab more medically you should inform whether it is a lateral or whether it is curvature
Sir,
of
in
anterior
scoliosis,
angle.
there is the
Because
in
man, because
scoliosis,
COPD patients will be most of the times having uh, kyphosis.
Kyphosis, yeah.
Okay, then that only will give more of barrel shaped chest. Think of it. And your patient has a history of tuberculosis. We don't know about the extension of radiological extension. So those patients will be having mild scoliosis also. If it had affected severely on the unilateral side, then the patient might be having scoliosis also. Normally the angle should be Cobb's angle according to you. It should be less than 10 degree. If it is
yes,
more
sir,
than
that
10
is
degree, then it is labeled as scoliosis. And based on the one beautiful chapter has been given in Fishman, you should read. Sorry, okay. One respiratory books may given. It's a very nice chapter for kyphoscoliosis. If you are free, you will read. You will love the book by reading that chapter. Okay. Anyway, from my side, you can go ahead because you have fixed your mind with only COPD as a diagnosis. So you couldn't think of you couldn't correlate of rest of the things. Okay. Next, please.
palpation finding. No local
Okay.
raise of temperature and no chest wall tenderness was observed.
The
Inspectory
second point
findings
should be
were
the first one, man. The inspectory findings are confirmed. Then only you should. Okay. Okay. You present, please. Sorry for the interruption.
yes. Sir, in some books it was mentioned on the second point that I had.
Okay. I accept.
Trachea was deviated towards the right side. Apex beat palpable in the left intercostal space, medial to the midclavicular line. Movement of chest were diminished in the right infraclavicular and bilateral infrascapular area. On measurements, transverse diameter was 23 centimeters and AP diameter was 25 centimeters.
Okay, man.
Elective
Nowadays, nobody's bothering about these measurements other than the crux. Like chest expansion is less than 1 centimeter. That is important. Normal chest expansion should be
4 centimeters.
4.
Yes, sir. Normal
I
chest
have
expansion.
7, man. Then what does it mean?
Sir,
I have 7 centimeter of chest expansion. It should be
more
more than 5 centimeter. Okay. It should
than
be
5.
more than 5 centimeter. If it is less than 5 centimeter, it is restricted. If it is less than 2 centimeter, the disease is more favor of restrictive lung diseases like ILD, or in other way, that's the uh, extreme of obstructive lung disease. Okay.
Okay, sir.
Okay. I would like to say 2-3 things. How will you check the palpation? How will you check the you have right? Normally it is not for family medicine people. Still, I would like to say normally a mild deviation on the right side will be there. But how will you check the tracheal deviation?
Sir, like 3-finger method is done for the checking the
Okay.
deviation.
Good. Okay.
We put the first and third finger on the lateral
Okay.
border of the
I understand, man.
sternocleidomastoid.
I understand. You will be knowing. 3 finger test is also there, and one more technique is called as insulation
Trace
technique.
line.
Okay. And in inspection, you should tell about trachea is in the midline or right side. You have told, na? Inspection mein, what is
Yes, sir.
trial sign? You should have mentioned about trial sign. Trial, TRAIL, trial
Yes,
sign.
sir.
What
Trail
does it
sign.
mean?
Sir, prominence of the sternocleidomastoid muscle is there.
Sternocleidomastoid ka which part? That is the question.
Of the clavicular head of the sternocleidomastoid.
Okay. Here I would like to say one point. Some books here again, some books say sternal head of sternocleidomastoid prominence, or some books say clavicular head of sternocleidomastoid. But actually, it is clavicular head of sternocleidomastoid should be noticed. Okay,
Yes, yes.
because clinical books has given some confusions. After reading these books and presenting the cases with many the legends, many the years, I have narrated these things, so I am conveying to you.
Yes, sir.
Okay, man. Okay. Uh, apex, you told, matlab, apex beat is not visible in the inspection. Now you have told it is palpable at fifth.
Intercostal. Sir.
Okay. What is the difference between apex beat and apical impulse?
Sir, apical impulse, sir, can be felt on the palpatory finding.
Then why don't you mention as apical beat? Matlab, apex beat, you have mentioned palpation, mein. Okay. The differences are there. You should clarify those things. Okay. Terms, they have their own meaning. You should clarify that. Okay. Next you can go, man. Next slide, please. From my side, you can go. You can go ahead.
On tactile vocal parameters finding, on the right side supraclavicular and left side supraclavicular both were normal. Clavicular side was also normal. On in infraclavicular findings, right and left both were having the decreased tactile vocal parameters, and in the axillary findings, both right and left were having the decrease. Only right was having the decreased tactile vocal parameters, and left was having increased. Infraaxillary and supraclavicular both sides were decreased, and interscapular both sides were decreased, and infrascapular left side was increased.
Nipun, can you tell in what all condition it decreases?
Ma'am, tactile vocal parameters?
Yes.
Ma'am, tactile vocal parameters, ma'am, increase in the
No, I'm asking for decrease in tactile vocal parameters.
ma'am, it decrease in the severe asthma, COPD cases, obesity, and ma'am, patient having higher fat or higher breast tissues.
Anything else? Your patient is having decreased tactile parameters mostly over the right side, right?
Yes, ma'am.
So what do you think it can be?
Ma'am, like increased air entry is there.
Okay.
Why increased tactile vocal parameters at axillary and infrascapular areas on left side, man? See, auscultatory findings, me you have mentioned right side affected more. Now, in tactile parameters, you have gone to left side.
In the infraclavicular and infrascapular areas, I observed the increased findings.
No, you have left side, me increased tactile vocal parameters. What does it mean? Increased tactile vocal parameters? That was madam was asking.
So increased tactile vocal parameters like can be seen in the cases of ILDs or consolidation.
Okay, okay, okay. Matlab, you go through this. These concepts should be very clear. You should not mix these things. And while presenting or while narrating the case, if you have confusion, just if you're not clear and matlab, not confident enough, just matlab, no, mention as normal. These points are creating confusion, na?
Sir,
Points
it
are
was
created. You should have mentioned. But I appreciate you. You have mentioned the matlab, the thing what you got in the clinical examination. I really appreciate for that. But if you are getting confusion, just leave it. See, always everything can be explained by something. If you are not able to explain, it means you don't know bus. Things are there, we don't know bus to explain. Anyway, next slide, man, from my side.
Go ahead, go ahead.
percussion finding.
Nipun, tell the significant findings, no?
Yes, on the infraclavicular right side, the patient was having the hyperresonant node. On the axillary side, right side, he was having the hyperresonant. On the left side, dull node was there. In the infraaxillary area, on the right side, hyperresonant node was there, and the left side, dull node was there. Suprascapular, both the side were having the resonant node. In the interscapular area, both the sides were having the resonant node. And in the
Got it,
infrascapular
man.
area,
Got it. But why dullness on the left side of certain areas? What do you think?
sir, if dullness is observed in the left area, so sir, patient can have any fibrotic patchy opacity or consolidations there.
But you didn't mention for those findings that area. Okay. Anyway, man.
And sir,
Anyway,
dullness
next.
can be there due to some pleural effusion.
Okay. Okay.
Okay,
Next.
go on next.
Auscultation findings.
Hmm.
Breath sounds were diminished in the bilateral infrascapular area with the right axillary and infraaxillary areas. Bilateral fine mid-inspiratory crepitations were heard, and bilateral and expiratory rhonchi were present. And vocal resonance was diminished in all the areas.
Okay. What are the conditions associated with the early inspiratory crepitations, mid inspiratory crepitations, and end inspiratory crepitations? You should know the DDs because those DDs will be helping you to come to the conclusion of this case. So you are not presenting a pure COPD. Did you get that?
Hmm.
Yes, sir.
Get that? You are not presenting a pure COPD. Your diagnosis should be something else.
The mid-inspiratory
Okay.
crepitations were heard there.
Seen in mid inspiratory crepitations are seen in matlab heard in.
Sir, it can be there in the patient with having the like pneumonia or fibrosis, bronchiectasis.
Yeah, mainly bronchiectasis.
Yes.
Mainly bronchiectasis. If the fibrosis has the bronchiectasis, then there also will be there. Pneumonia may mid inspiratory.
No, sir, and expiratory bronchi will be
Okay,
there.
go through, man. Go through the book. It's not so. Okay, next. From my side, you can move to next slide.
Okay. Nipun, go ahead. Nipun.
On the cardiovascular
Okay, there is
findings,
no significant. Okay,
Yeah,
I think
yeah.
you can skip.
I think we can go ahead, Nipun.
yes.
Tell the significant things now. Okay.
As we summarize our case, elderly male patient, reformed smoker with a known case of pulmonary TB and COPD, presented with the worsening breathlessness, MMRC grade 1 to MMRC grade 3, with the chest heaviness. On examination, he is a thin built, had grade 1 clubbing. There was barrel-shaped chest, right-sided decrease in the chest movements, hyporesonant node on the percussion with the decreased breath sounds, and there was loud ST. Probable diagnosis can be a case of acute expression of the bilateral obstructive lung disease with pneumothorax. Emphysema predominantly secondary to the chronic smoking without any evidence of core pulmonary or respiratory failure.
Okay. Matlab, I have doubts in that, but still, man, I would like to say one more thing. MMRC grade you have told, na? MMRC grades, what are the grades? Just tell the grades. No need to explain the things.
Sir, in MMRC grade 0, breathlessness is observed only with the
No,
brain
not
as
needed. 0, 1, 2, 3, up to till
4.
4. What is MRC? What's the difference between MRC and MMRC?
Sir, MMRC is Modified Medical Research Counseling Gradient.
Okay, man. Previously MRC it was 1, 2, 3, 4, 5. MMRC means 0, 1, 2, 3, 4. Okay,
0, 1,
that
2,
you should know. Okay, man. Matlab, anyway, you have fixed with pure COPD. So next, if you want to show matlab, how will you matlab, evaluate this patient? You have diagnosed the COPD. How will you manage this patient?
Sir,
Go to the management part now, Nipun.
yes, sir. Investigations, what we have ordered was CBC, ESR, and LFT. And on the initial ECG, he was having the signs of sinus tachycardia, and ABG was
Okay.
suggesting of hypoxia.
Understood, man. Relevant finding only, but the TLC has increased up to
Yeah,
17,000.
on day 1 it was 17,000, which after starting IV antibiotic it improved. Okay.
Okay. Matlab, you have done relevant investigations for this. Will you do if the patient has carpulmonale? If the patient has carpulmonale, what would be the ECG finding?
Sir, patient will be having the MAC.
Okay, you should go through that. Okay? Matlab, you should
I'll-
know that.
Yes, sir. Multifocal lateral
What will
tachycardia.
be happening with the R waves? What will be happening with P waves? What is P
Yeah,
pulmonale?
so the right heart changes will be there, right?
Yes,
Yes.
ma'am, right-sided heart
You
failure.
should mention that.
Okay.
Okay. Then next.
Yeah.
Sir, this is a chest X-ray. We did it on the 1st of December.
Okay, okay. If possible, I will take. If possible, I will take one X-ray class also, man. I would like to take
So
X-ray classes for
we
you.
would be really happy to do that, sir.
Nipun, Nipun,
Yes, sir.
just tell the positive finding of this X-ray.
Sir, patient, the
This is
CTR.
matlab, this is a recent X-ray, na?
Yes, sir.
Yes,
Yeah,
sir.
this is 1st December.
The
Okay,
patient,
okay.
So I just
Just
wanted to tell one thing. This is the 1st December X-ray, and we have, I think Nipun will be telling that regarding HRCT also. And next, he has included the previous past admission extra also for discussion.
yes, ma'am.
okay.
Tell positive
Nipun,
findings, no, Nipun.
Ma'am, patient is having the tracheal division towards the right side, and ma'am, multiple emphysematous bulle changes are observed in the bilateral lung fields, mainly in the right-sided upper lobe and the lower lobe areas. Predominantly right-sided pneumothorax, right-sided blackening of the air is there, suggestive of the right-sided pneumothorax, and ma'am, homogeneous opacities is observed in the right-sided as well as the heterogeneous fibropatchy opacities are also seen in the left-sided lung field.
okay. Okay. Uh, okay, good. Nipun, these calcifications are there, na? Cavity
Yes,
calcifications, fibrosis, and
Fibro
bullous changes.
calcifications.
Yeah. What is macro calcification and what is micro calcification and what is the duration for that, man? What does it mean? This patient has macro calcification. This is macro calcification. Matlab visibly we can see. Microscopic calcification means tissue will be showing calcium congregations. Macro calcifications say the patient had TB at least 1 year ago. At least it will take 1 year to develop these calcifications. Okay. Hello.
Yeah, yeah, yes, sir.
sir, I can hear
Yes,
you.
matlab by listening, but you see, somebody has given the X-ray only, and they are asking the detail of the patient. You have to tell the patient had post-infection, mainly tuberculosis, because it is associated with the cavities and associated with the calcifications. So fibrocavitary calcifications are seen. Might be due to tuberculosis. You will be telling. Okay, pneumothorax. How do you say this is pneumothorax?
Sir, black zone areas can be observed in the basal area of the lungs. Black lung
That
field.
can be seen in bulla also, large bulla also. Then how will you differentiate?
Sir, in Bulla, the like the opacity is in the like is having a rounded margin and confined in one areas, and absence of bronchovascular markings are also seen.
This is also not fully matlab evolved pneumothorax nahi hai na.
Yeah,
This
yeah,
is also
yeah.
only located hai.
Yes, yes.
Why matlab will you? Okay, certain points are there. You should know how to differentiate a bulla from a loculated pneumothorax. Okay, you
It is
should
a
know
case
these things.
like loculated pneumothorax with Bulla rupture.
Yeah, how will you matlab you should know, you should know. Okay, I hope you know. Okay, you want to present next, you can move ahead. Karishma ji, you can move.
So this is a
Okay,
HRCT of the
yeah,
lung.
severely damaged.
Yes, sir.
Okay. Yep, the first one is the X-ray point view. That is the scout view. The scout view will be telling about the overview of all the films. Matlab, this means the patient has undergone only CT thorax. Sometimes the scout view will be showing both the CT thorax, CT view, thorax view, and the abdomen view. It means you can ask the patient, where are the rest of the films?
Yes,
Matlab,
sir.
it means the patient undergone only chest CT. That
I
will
have
tell about
observed.
the patient that has undergone. Okay, that is scout view. The first part, the first CT is the mediastinal window. Always that is the one first to be read during CT reading. And the second one is the that is lung window. Second one is the lung window. Okay. What does matlab, do you see any mediastinal lymph node in this? No, fibrotic changes are only there. Okay, man. From my side, I got the CT. I got the CT findings.
Localized pneumothorax is there in the right side,
Okay.
and multiple calcific nodules can be observed in the lung parenchyma. So, most probably suggesting of the old case of pulmonary TB or granulomatous changes.
Okay. Okay.
And COPD changes can also be observed.
See, your findings were increased on the left side, tha na? Matlab, that might be normal and the right side might be decreased, isn't it?
Yes, the right side
You
was
told vocal parameters left side increased infraxillary, infrascapular. I'm
right
telling
side.
instead of that, that was normal, left side was normal, and the right side might have been decreased, diminished vocal parameters and everything. Okay, anyway, it should be discussed in detail. Next, can you please move ahead?
Yes, sir. So this is the city
Okay,
report.
I got it. I got it. For others, you can read it. For others, you can read it. For the participants in this group, they can. What do you want to say? CT report.
Bilateral lungs were showing the marked architectural distortion, and diffuse emphysematous changes were observed. Ill-defined localized pneumothorax was noted on the right side, with a thin incomplete septations along the lung parenchyma, which may be due to the secondary to bullous rupture. Multiple dense calcific foci are noted in the lung parenchyma, likely due to the old granulomatous changes. And the findings are suggestive of the extensive COPD changes, with localized pneumothorax on the right side, likely secondary to bullous rupture, and no signs of active infections.
Okay. Okay. Next.
So these are the chest X-rays of the past admission.
Okay. Okay. Got it.
When he was admitted 6 months ago.
Okay. Okay. It means it can be a recurrent pneumothorax as per the definition. Okay. Next.
Yes.
Next.
This is the HRCT of the past admission in the month of June.
Okay. Okay. Okay.
So, sir, in this CT also, sir, the COPD changes are there with the bulla in the bilateral upper and the lower lobes of the lung.
Okay. Okay. Next. Because it's running beyond 1 hour, listeners will not be that much patience. Next.
So this is the
Next.
CT report of the.
Okay, man, it's a old one, na? No need to. Chudi echo you have
Sir.
done. The patient does not have PAH.
Yeah.
Hai na?
Yes, sir. Yes, ma'am.
Okay, okay. Okay. Then what is the now? What is the cutoff for saying PAH, man?
Sorry, sir.
What is the
Cutoff.
value?
Sir, for pulmonary arterial hypertension.
Yes, yes.
Yeah. Previously it was 25. In 2019 they have changed into 20. Okay, if it is more than 20, then PAH will be considered.
So more than
Okay, next.
20.
Matlab, you have given antibiotic. Okay, patient oxygen you have given.
Yes, sir.
Okay.
Sir,
Do you
augmented
want to show?
ventilation.
Okay, man, got it, got it. Next, you want to show because man, already I have time, but listeners will not be having.
Yes, sir.
Okay, okay. See, okay, this case has a, matlab, the patient has loculated pneumothorax also, and the patient has COPD changes also. The patient has post TB changes also. So why a mixed finding you got in the examination?
Yes, sir. That's why the tactile vocal parameters and auscultation was not.
Okay, if you do, will you do PFT? Will you do PFT for this patient?
Yes, sir.
Will you do after seeing the CT?
No, sir. Actually, pneumothorax is there, so we
Yeah.
can't
See,
go for the.
generally pneumothorax is a contraindication, but these like loculated pneumothoraxes are relative contraindications, and large bullas.
Bullas are there, yeah. So
Large
the
They have relative contraindication. Okay, if okay, man, Madhav, you have presented well, and I appreciate your.
I just want to ask one question to you, Dr. Nipun. So you nebulize the patient with Dolin and Budate. Now, considering your patient is having COPD, and if any other patient with COPD may not be having other comorbidities, what will be the treatment from your side for a COPD patient on discharge?
On discharge, ma'am,
Yeah.
we have to put him on the nebulization. If,
At home, will you put him on nebulization? Can you give MDI? Can you give inhalers?
beta dose inhaler can be.
Yeah. So what would we like to? The choice of drug will be.
Short acting, long acting beta 2 agonist.
Okay. And when you want to escalate it?
Like if the patient is not feeling improvement of symptoms.
Okay, so the choice of escalating this thing, the first thing is the LABA or LAMA. Okay, depending on the rate of the exacerbations, how many exacerbations he is having, or whether it is requiring hospitalization. Okay, and acute exacerbation, you can give SABA to the patient. It is short-acting beta 2 agonist. Okay. Okay. One more thing I wanted to, you have written pneumococcal and influenza vaccination. That is good. And I think it should also include COVID-19 vaccination also. Sir, I want to ask you one thing, Dr. Shankara.
Yes.
Yeah. What is the definitive treatment for a patient who is having recurrent pneumo due to the rubella rupture?
Ma'am, in these like conditions, we will be inserting the tube and pleurodesis might be considered. Pleurodesis.
Okay.
Pleurodesis will be preventing further. But if the patient has a plan of lung transplantation, then pleurodesis might be a worry. Previously they told if a patient undergone pleurodesis, it will be lung transplant. During lung transplantation, separation of the lung will be difficult. But nowadays it's not a contraindication. But pleurodesis will be when the patient has recurrent pneumothorax, we should always advise for pleurodesis in these patients. It will prevent the recurrence actually.
Yeah. Thank you, sir. You want to say something, Nipun?
Yes, ma'am. I was saying that pulmonologist is here suggested for the IT insertion, but if the patient was having recurrent pneumothorax with the emphysematous changes, so they have denied for the same.
Actually, these loculated pneumonia should have been trained. Then they should have considered for see loculated pneumothorax per se no need to manage, but it is a recurrent one or increasing with symptoms. Then it should be addressed. And we have seen cases and we have managed with pleurodesis. We have experience of talc plus doxycycline plus povidone iodine experiences, especially for the last 2 years we have done lots of talc pleurodesis. Good experience with talc we have. It should have been done. Anyway, you have done nice presentation, man. Congrats.
Nipun, considering, I think Dr. Shankar, I just want to tell you, he is just joining 2 months back only. He has joined, and I think you have done really wonderful presentation, Nipun.
Yeah.
Okay, just keep this thing up and be doing this thing and later years also. I want you to read few things, the examination part and all, and also the treatment of COPD. What is LAMA? What is the first line drug used for the COPD in terms of MDI? What is LABA? What is LAMA? And what is short ASABA? And then what else you can give when you start inhaled corticosteroids also, that you should know. Okay, and rest obviously the respiratory system examination is very important. You should do practice it in next coming 3 years. Okay. Okay, very good presentation, Nipun.
Nice presentation. Really, you have done good job, man. And thanks for the organizers.
Thank you, Dr. Thank you, Dr. Shankar. Thank you, sir. Thank you
Lastly,
so
I want
much.
to join in. I believe this is a highly educational and interactive session, an excellent presentation by Dr. Nipun and some great moderation by Dr. Shankar sir and by Dr. Shalini ma'am. This is the first session of Chris presentation under the aegis of Spice Route Rajasthan chapter. I'm sure this is just a beginning and many more to come soon. With a special thanks to Dr. Shankar and Dr. Shalini ma'am. With this, I bid adieu from all of you. Good night.
Good night. Okay. Thank you, Dr.
Thank
Shankar,
you,
for such a
everyone,
good input.
for joining.
Yeah.
Thank you, Nipun. Thank you. Thank you all.
Thank you, sir.